Online Michael. Good afternoon to you all. Welcoming you all to the 49th City Pathology Meet. Sharp 2. Can we start? Can we go on with the first presentation?
Good afternoon, ma'am. Yes, ma'am.
Dr. Deepthi, are you ready?
Yeah, yes, ma'am.
After Dr. Deepthi, Sita Lakshmi ma'am from Mehta Hospital will be presenting. So, Deepthi, kindly share your presentation.
Yes.
Ma'am, yes, ma'am. Solunga, ma'am.
I don't want to sort of, trespassing somebody. So,
ma'am,
slower. You're able to hear me?
Please, solunga, madam. Okay, madam. Okay, madam. Then we'll see if Josephine is ready. We'll ask her to present.
So slow.
Hello, ma'am.
Deepthi, your screen is visible. You can start.
Okay, ma'am. Good afternoon, everyone. I'm Dr. Deepthi, Senior Registrar from Apollo Hospitals, Chennai. I'm going to present this case that is 34-year female nulliparous presented with profuse vaginal blood bleeding and abdominal pain. Their clinical finding is recurrent multiple endometrial polyp. And what specimen we received is endocervical polyp. Grossly multiple polypodal. Ma'am, it's clear, ma'am.
Hello, yeah. Go on, Dr. Deepthi.
Multiple polypodal.
Yes, ma'am. Ma'am, solunga, madam.
Yes, ma'am.
He's joined here. He is a pediatric surgeon for whose case we are presenting today.
Okay, ma'am.
So that is why I wanted to have it a little early because they're all busy surgeons, no?
Ma'am, shall I continue?
Yeah. Deepthi, you can continue. Up next case present பண்ணிடுறீங்களா?
Yeah. He is waiting.
Multiple.
Okay, ma'am. Dr. Deepthi presentation முடிஞ்சிட்டோன்னா உடனே present பண்ணிடலாம், ma'am.
Yeah.
Thank you.
Rahul, you're able to hear, no?
Yes, ma'am. I'm just waiting.
Let Dr. Deepthi present first.
Yes, sure, ma'am.
Ma'am, it's echoing actually.
Okay. Yeah, Deepthi, please.
Yes, ma'am. Shall I continue?
Yeah, please continue, Deepthi.
Clinical findings is recurrent multiple endometrial polyp. But what specimen we received is endocervical polyp. Grossly multiple polypodal tan brown tissue fragments, maximum diameter of 2.5 centimeter, cut surface mucoid and glistening. MRI.
Your slide is not moving.
MRI, it showed endometrial thickness of 10 mm with ill-defined intracavitary lesion from posterior wall of lower uterine segment. These are the histological slide pictures. Here, we find polypodal fragments composed of multiphasic, biphasic tumor composed of benign endometrial glands, benign endometrial glands and atypical stromal component. The typical finding is that these all benign glands has stromal condensation, and we have find in the stromal component some heterogeneous cartilage differentiation. In high power, these glands are lined by benign cuboidal epithelium. These glands have focused squamous metaplasia with prominent stromal condensation. And the atypical stromal component composed of atypical mild to moderate spindle cells with many mitotic activity more than 2. So based on the morphology, benign, it's echoing. Based on the histology morphology, benign glands with prominent stromal condensation and atypical mesocommon, we made a diagnosis of Mullerian adenosarcoma with stromal outgrowth. So coming to the discussion, biphasic tumors of the genital tract includes atypical polypoid adenomyoma, endometrial polyp, adenofibroma, Mullerian adenosarcoma, carcinosarcoma, low-grade endometrial stromal sarcoma with glandular differentiation. In this entity, this carcinosarcoma is ruled out because the both components should be malignant. So in this adenosarcoma, we have glandular component which is dilated, which is benign. In adenofibroma, atypical polypoid adenomyoma, low-grade endometrial sarcoma, and endometrial polyp. In all these entities, the glandular component is benign. And this is a typical periglandular cuffing, which is prominent only in adenosarcoma. And stromal atypia and mitotic index more than 10 we have seen in our case. To confirm the diagnosis and also to rule out other sarcomatous differentiation, we did IHC panel. Here CK, which is positive in benign glandular component, and the mesenchymal components are positive for vimentin, desmin, CD10, and P53, and K67 was more than 50. And additional markers like SMA, which is focal, myogenin showed focal positivity, and HTTDesmo negative, and ERPR negative, WT1 negative, which again rules out endometrial stromal sarcoma, and P40 to rule out spindle cell sarcomatoid carcinoma.
Excuse me, Dr. Deepthi, see that on your screen, you have that ad or whatever. Can you just take it away?
Sure. This one. This one, ma'am?
No. And the upgrade to K7 mobile security in the screen. Yeah, thank you. Sorry, continue, Deepthi.
Wow. So little about adenosarcoma of cervix. It's a rare malignant biphasic Mullerian tumor. It can occur in any age group, most commonly concentrated in peri and postmenopausal women. It composed of phylloid-type benign glandular epithelium with cellular stroma with varying degree of atypia. This atypical stromal component is the malignant component. The stromal component can be either low-grade or high-grade variants differentiated by the presence of pure sarcoma comprising more than 25% of tumor. In our case, this sarcoma component accounts for more than 25% of the tumor. The Ka is 65 index and abnormal P53 may be the hallmarks of high-grade tumor. In our case, the Ka67 is more than 50 and abnormal P53 is seen. What are the variations of stromal components? It can be uniformly low-grade sarcomatous component or high grade sarcomatous component or sarcomatous overgrowth by the high grade component, which will be more than 25. What are the molecular alteration in adenosarcoma? Amplification of MDM2, T53 mutation in high grade tumors or overgrowth, ATRX mutation or loss in some tumors, Dicer mutation if rhabdomyosarcoma differentiation, copy number gain in MIB-L1 usually with sarcomatous overgrowth, or mutation in FGFR2 or KMT2C. What are the prognostic factors? Prognostic factors depends upon depth of myometric invasion, presence of high-grade features like sarcomatous overgrowth, if the tumor is in the extra uterine spread, or if it's the patient presents with a recurrent polyp, or the patient having lymphovascular invasion. These are the features of these are the poor prognostic factors. What is the treatment effect? Is the treatment basically hysterectomy and bilateral salpingo-oophorectomy. If it's inoperable, we can treat with radiotherapy or chemotherapy. Thank you.
Thank you, Dr. Deepthi. The case is open for discussion.
So cartilage looks abnormal.
No, ma'am, it was chondromatous cartilage, image of cartilage.
Phylloids. Yeah, the other. This one, the last one. Nice case, Deepthi.
Thank you, ma'am.
Very long time. We have seen it during our PG days.
Thank you.
Okay.
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 Thank you, Dr. Deepthi. Can we go on to the next presentation?
Thank you, ma'am.
Mehta Hospital.
We are ready.
Dr. Kavya, Dr. Kavya.
Yeah. Yes, ma'am. We'll share. Ask them to close this.
Yeah.
Okay. Slideshow. Okay. Slideshow. Okay, slide control. Look at that. Yeah.
The shot.
You are able to see the slide?
No, ma'am. Not yet. Yeah. Yes, ma'am. Yes, ma'am.
That's why we call some.
Dr. Kavya, you can start your presentation.
Yeah, yes.
The others, kindly mute yourself.
So today here we are presenting a case of 5-year-old female abnormal eye movements and gain disturbances in the form of pain for the past 3 months. Following these symptoms, CT brain, CT chest and abdomen was done. A well circumscribed mass of 3 centimeters situated in the left paravertebral region, partly encasing the aorta, was identified. Excision was done. So this is the histopathology picture where we can clearly see 2 elements juxtaposed to each other. So one element, as we can clearly see, there are mature ganglion cells in a pink Schwannian cell background, while the other element is showing irregular nests of dark blue cells in a eosinophilic background with some congested cells. So following this immunohistochemistry revealed in the chest the stop cell is positive, revealing the neural synaptophysin and chromogranin and CD56 also positive, indicating the neuroblastic differentiation. NF is also positive. Mu N turned out to be negative. It is a marker of mature neural cells. So this marker came out to be negative, indicating that it is an immature component. CD99 is negative, excluding many other small round blue cell tumor. ALK1 is negative. GFAP is negative, indicating that this is not glial and it is belonging to Schwannian group. Cytokeratin is negative. K67 is showing only 2 to 3% and is very low. So, as we can see clearly, next slide. So we made a diagnosis of ganglion neuroblastoma. So the above mentioned clinical presentation is oxoclonus myoclonus which is a new neuroblastoma. This gains its pathological significance because it is a paraneoplastic autoimmune response targeting the neural cells. So the pathophysiology and paraneoplastic mechanism behind this, the neuroblastic cells express the neural antigen and the immune response cross-reacts producing autoantibodies. These autoantibodies attack the cerebellum and brainstem, which caused the clinical symptom of the and myoclonus.
Balan, please ask others to unmute ma, because mute panna solluma. There's so much of background talking.
Yeah, ma'am. Just checking. I'll do it.
Please. Somebody is going on talking in the background.
The others, please kindly mute yourself.
So the Shimada classification and the International Neuroblastoma Risk Group classification divided the ganglion neuroblastoma into 2 types. One is intermixed and other one is nodular. So ours is nodular type. As we can see clearly, 2 elements. Intermixed has the best prognosis, while the nodular type depends upon 3 indices. One is mitosis karyosis index, which is low in our patient, and then c-MYC amplification status, which is negative in our patient, automatically shifting the case to low risk category. As we can see, differentiating it from other small blue round cell tumors is also essential. which we had already done in immunohistochemistry. Thank you.
Dr. Rahul, you are still there?
Yes, ma'am. Yes, ma'am.
Please, I want your input in this case because this is a very rare syndrome and this was one of the classical example of a paraneoplastic immune-mediated phenomenon. I would like your comments and the progression and how is the patient doing, all that.
Yes, ma'am. Thank you so much for the opportunity, ma'am, and highly appreciate the way you have been giving us all our reports extensively. With regards to this child with an opsoclonus myoclonus syndrome, we all know that usually for any other tumor in a child, usually the mass will be the presenting symptom. For example, a Wilms tumor or a rhabdomyosarcoma. But in opsoclonus myoclonus syndrome, the initial presenting part will be neurological. The child will present to you with ataxia and opsoclonus syndrome, and finally we'll be able to see such an indolent mass. So it is actually better for the surgeon because neuroblastomas usually are not identified such early, but they are very indolent. Only when they grow to a huge mass, causing mass compression or encasing the vessels, we usually identify. And most of them are either at the thoracic level or at the abdomen level. We in fact had 2 cases in the last 3 months where one was encasing the renal artery, and other was encasing the aorta. So once this mass is identified, it is amenable for easier excision. One. Number two, post-operatively because of good prognostication. Most of them are ganglion neuroblastomas, as Kavya ma'am has already told us. So it will be either a ganglion neuroblastoma or second is only neuroblastoma. Because most of them are ganglion neuroblastomas, we don't mandate them or need them to subject them for chemotherapy, radiotherapy, or an autologous bone marrow transplantation. So it will be just an R0 resection, completely resecting tumor mass, good prognosis overall. But the only hitch here is it is not only a surgical perspective. Though chemotherapy and radiotherapy are not needed, these children will need immunotherapy for a long time. Because as the pathology has already been discussed, it is mainly because of your antigen antibody reaction to the Purkinje cells of the cerebellum. So there is actually, if you look at the pathophysiology of the Purkinje fibers, Purkinje cells, there is a loss of Purkinje cell fibers.
That's all? That's all, Dr. Rahul? Hello?
Ma'am, I think that's all. I think he has shared whatever needed, I think, Dr. Rahul.
To have contributed some of the points to the
Yeah,
highlight.
definitely, ma'am, definitely.
Yeah, and the highlight was
Now,
made.
because the
Yeah, please continue, Dr. Rahul.
Yes, because the B cell activation abnormalities are more rampant. Now we have rituximab as the second line drug, which is now implicated as one of the first line drugs for treatment in these children with opsoclonus myoclonus. So this child at present is doing absolutely well. We had a complete tumor excision. The good part is I was able to do it thoracoscopically. Though it was encasing the aorta, there was no open surgery. It was completely done laparoscopically or thoracoscopically, where the entire tumor mass was delineated and excised completely. The child recovered. The next day, child was hopping around inside the hospital, and the child was discharged. And the second or third day, child was doing absolutely well in discharge. Child is on rituximab, and child has devoid of any other symptoms post surgery, post 2 cycles of rituximab. And we are looking at a good long-term prognosis for this particular kid. So I think the diagnosis at the right time made us go through a wonderful journey in this kid with opsoclonus myoclonus.
Very good, Dr. Rahul. You have been, I think you must be very happy that you have done a good thing for the child. And the parents also must be very happy. Thank you for your time and contribution, Dr. Rahul.
Thank you so much.
Yeah, thank you. So we'll go to the spotter. I think I'm taking much of your time. The spotter, anybody coming out with any diagnosis? Bladder mass in a young female, 42 years, urogram showing a moderately enhancing lesion. And you can see the arrow pointing out to the bladder urothelial lining and also the mass lined by any diagnosis, anybody offering any diagnosis?
Madam, நம்ம பிஜிஸ் வந்து cystitis glandularis ன்னு சொல்றாங்க.
Cystitis glandularis, then what are the cystitis glandularis of the bladder? Will you have mucinous columnar epithelium with a basal nuclei? Cystitis glandularis is a conference nest giving rise to cystitis glandularis, right? Anyway, See, clinically, this patient had a resected mass in the bladder with a moderately enhancing lesion in the urogram. And in the intraoperative finding, which I did not give that, otherwise it will give away the clue. That was actually, they visualized some kind of a chocolate-like material coming out. And so the clinical impression was endometriosis. But what you find is an endocervical epithelium, right? So we called it endocervicosis. This is a type of a benign Mullerian lesion comprising of a mucinous tall columnar lining mimicking a lung. It is an endocervix, but considered as a variant of endometriosis. Other type of inclusions include endometriosis and endosalpingiosis. Endometriosis is Endometriosis is identified with the help of endometrial type of glands and stroma. Endosalpingiosis with cilia and intercalated plexus. But here, it was not, it was actually, you can see the endocervical epithelium. Of course, we have not included the other pictures where we had more of endocervical glands which are absolutely benign. And the most important reason why I included this is this kind of mucinous columnar epithelium in the bladder, one has to consider the possibility of adenocarcinoma, which is arising from the bladder. And if it is a female, then definitely you have to think of a endocervical carcinoma metastasis into the bladder. But all of them are malignant, whereas here you can see the benign endocervical epithelium with the basal nucleus and a single line. So this is a very rare, very, very rare entity in the bladder. The first time I'm seeing in my 40 years of pathology experience. And the terminology also, though it is called endocervicosis because of the endocervical nature, otherwise it is actually considered as an endometrial variant. And the clinician said, no, madam, it is only endometriosis. But then we have to explain to him that it is also considered as endometriosis, and the treatment given is as per the endometriosis. But then here it is a metaplastic Mullerian, metaplastic mucinous epithelium, which is seen there. So that is why it became a very interesting case, because the first time I'm seeing, I do not know whether anybody else has reported it.
Is the patient having endocervicosis in the cervix also for this patient?
No.
Cervix biopsy not done.
No. They only a bladder.
That I know, but I'm saying concomitantly, is she having, because we have seen many times endocervicosis in a regular cervical biopsy specimens. That is why I'm asking.
No.
Okay. No, that capacity of just maybe very nice, rarely.
Very rare lesion. That's why we thought.
Correct. The other one?
The next spotter. This is a 36-year-old female with all the private eye history is given there. She has a miscarriage. Now she underwent the suction evacuation, and the products were submitted to us. What do you see there?
Villi.
Yes.
Atrophic villi, nose, very thin cytotrophoblastic reaction.
Very less. Actually, grossly, it was all only placental tissue, which were very, very edematous and spongy. There were no vesicles or so-called grape-like vesicles that we see in the case of a vesicular mole. And I talked to the clinician, and they also said, madam, we didn't have the possibility of a vesicular mole. It is only a placental tissue. Now, this is an entity called a placental edema, or otherwise called, just like we all know about hydrops vitalis. This is called a placental hydrops, which is a very, very distinct entity. And it can be either, or, she has had so many abortions. So she must have had some problem there. Genetic, and we didn't have the full history. The etiology can be either immune or non-immune. Immune is associated with the hemolytic disease of the newborn. Non-immune can be associated with any of the congenital anomalies in the fetus, torch infection, etc., and the maternal factors of diabetes and malnutrition. But it has to be excluded from vesicular mole, which is usually a partial molar degeneration. So what area you suggested was right, because there is a very, very important differential diagnosis. That's why I called the clinician and I asked her what was the beta HCG. She said there was no necessity for them to do the beta HCG because they never thought of a vesicular bone. So what is the difference between a partial and hydropic change in the placenta or a placental? It is relatively a smooth villus contour. I'm sure all of you would have seen. It was a single layer, very, very smooth, intact. And there are no vascular, it is a degenerated vascularity was there in the hydropic change. And you have a fully filled with eosinophilic secretions, eosinophilic or edematous kind of a fluid. But there were no cistern, as you see in the partial mole. And nucleated RBCs will be there sometimes in the partial mole, whereas it is not here. And of course, the risk of malignancy is more in the partial molar degeneration, but not in the hydropic change. So this was the first time again we are coming across a placental hydrops. So I thought both these cases definitely worth sharing with all the fellow pathologists. So in case they come across this, they can also be of this presentation will be of use. So that is the reason why we presented these two spotters. Thank you. Thank you for the opportunity.
Madam, shall I ask a question, madam? Good evening, madam. Nice cases. Nice cases, Sita ma'am.
Yeah. Yes.
Ma'am, just out of curiosity, I'm just asking, fetal hydrops, was there any fetal hydrops associated with placental hydrops? Usually we have that both together. Hepatosplenomegaly, madam?
I know. It is Gandhi, right? Gandhi?
Jayalakshmi, madam.
Jayashree,
Yes, Jayalakshmi, madam.
Okay, Jayashree.
Yes, ma'am.
No, Hydra. See, this was not a case of HCN or anything. There were no hydrops fetalis. It is only Jayalakshmi. Yeah. So Jaya, this is associated.
Yes, ma'am.
Little. I know. How are you?
Fine, ma'am. Fine, ma'am.
Yeah.
Fine, ma'am.
Very good. So nothing, Jaya, nothing. I mean, it was only a placenta, it was suction evacuation with the 20 placenta. So there is no question of.
Yes, ma'am.
Okay, so
yes, ma'am.
How do we report on this, Sita? How do we report on this in the description? Inference.
I had given it as placental edema and a placental polyp, but nevertheless, I had concluded because of some, as you said, some areas of trophoblastic proliferation and some areas of normal size to villi. And so I said, nevertheless, a chorionic endotropic examination has to be done to rule out the.
Okay. Follow-up, clinical follow-up you would have told.
Madam, weight of the placenta, was it okay, madam? Was it more?
It was only a suction.
Only suctional. It was an abortion then. Okay, madam. Oh, yes, madam. Oh, yes, madam. Okay, madam. Because most of the cases in clinical, they have fetal hydrops, hepatosplenomegaly, full MSR, and the mother baby was the BOH. Cesarean pandon settu pedu, madam. That's what I'm asking. Yes, madam. Thank you, madam. Thank you.
This is also.
Ma'am, thank you for those wonderful case and the two spotters, ma'am. Thank you, Dr. Kavya. And that was a great discussion. And can we go on to the next presentation? Dr. Josephine from Ramchandra Medical College, are you ready?
Yes, ma'am. Yes, ma'am.
Please share your screen.
My screen visible, ma'am?
Yeah, Dr. Lavanya. Dr. Josephine, please continue.
So good afternoon all. I'm Dr. Josephine from Sri Ramchandra Medical College, and today we have a case of a 23-year-old male who's a known case of hypospadias and right undescended testis, and who underwent stage 1 orchidopexy and hypospadias repair. The material sent to us was the right dysplastic testis. So radiologically on the right side, there was a roughly 3 by 2 centimeter thick-walled anechoic cystic lesion, and it was seen extending through the inguinal canal, but not into the scrotal sac. And also there was a small 8 by 4 mm hyperechoic lesion with internal vascularity, which was suggested as periatrophic testis. Left-sided, there was a undescended testis like mass. So the impression given in radiology was left undescended testis and query right encysted hydrocele with atrophic or dysgenetic undescended testis. So this is the material, was the right dysgenetic testis was sent as. So you can see it's a very irregular looking mass. It was firm, softer form. A lot of gray-brown areas with some gray-white areas in the center like this. There were small spaces in between, slightly larger than slit-like spaces. The radiology we saw was predominantly what we are seeing offers fallopian tubal epithelium. So we can see the 9 ciliated epithelium with PEG cells in between. And just beneath the epithelium, we're seeing a lot of congestion, a lot of chronic inflammation, lymphoid follicles with germinal center formation also we can see here. So the same thing, it looks a lot like the tubal plicae that we would normally see with, this is a hyper view to show you the PEG cells in the tubal epithelium and underlying lot of chronic lymphoplasmacytic infiltrate and a lot of congested blood vessels. So we went ahead, this is all we saw, but we went back to the gross. We gave some read bits from some slightly yellowish looking areas. So that's when we found these a very ill-defined vasculature, which resembles a little bit of rete testis. And in the corner, you can see a dilated structure, which looks a little bit ciliated, looks a little bit like the epididymis. And here, somewhere towards the left bottom, you can see some small ill-defined tubules. So then we came across these areas also. So we can see some tubular areas and in high power. So we thought these look like certainly only cells in a case of inside the seminiferous tubules. So with this, we gave an impression of features are that of disorders of sexual differentiation, since we're seeing both male and female gonadal parts. And we gave a comment that in correlation with the clinical findings and the HME features are that of disorders of sexual differentiation suggestive of mixed gonadal dysgenesis. Now, first we have to understand the differentiation into the male and the female. And we know that in the male, the Y chromosome contains the SRY gene, because of which testicular development happens. And then there is anti-Mullerian hormone, which causes Mullerian regression and promotion of the Wolffian development structures. So there are many disorders under this category, and we can group them like this according to their karyotype, or in our case, it is easier to group with the histology. So we can see a varying histopathology here. It can range from absence or undifferentiated gonad to ovotestis. So we have classic streak gonad, hypoplastic ovary, and streak gonad with epithelial cord-like structures. Ours fits in more with the dysgenetic testis. Why? Because dysgenetic testis is ideally a small testis. So you see a small tubular grouping in the center of the gonad, and in the peripheral area we see a lot of stroma, which may resemble like above ovarian stroma or any part of the Mullerian development. In post-pubertal cases, we will see an incomplete maturation of Sertoli cells where spermatogenesis is absent. There may be associated Leydig cell hyperplasia. The stroma may be similar to the ovarian stroma. So when you get a dysgenetic testis, you have 3 primary differentials. Mixed gonadal dysgenesis is the top. Male dysgenetic pseudohermaphroditism is a variant of mixed gonadal dysgenesis only with slightly different clinical features. And in the then finally you have the Mullerian duct persistence syndrome, which is basically a male with the uterus. So our diagnosis was a mixed gonadal dysgenesis. Most commonly, you see a mosaic pattern of 45X and 46XY. So both of this will be present in the patient. You have partial presence of the SRY gene with incomplete AMH effect. So Mullerian structures will often be present in these males. So usually, characteristically on one side, you will find the dysgenetic testes, and on the other side, you find streak gonads. But that depends on whether 45X is dominant or 46XY. So same, in accordance with the karyotype, you can have cases with streak testes, or just streak gonads, or dysgenetic testis. But majority of the cases, one of these will definitely be present with a fallopian tube. And the level of testicular development is in correlation with the level of the Mullerian duct regression. So exactly, again, similar to the karyotype, you can either have a male phenotype or you can have a female phenotype depending on which is dominant, or you can have an ambiguous genitalia. So if you have a male phenotype, you can have bilateral streak testes with symptoms like infertility, azoospermia, hypospadias. If you have a female phenotype, you can have bilateral streak gonads with short height, some Turner-like features also, then heart and kidney abnormalities. Or you can have ambiguous genitalia, where you have bilateral dysgenetic testes or one with a streak gonad. But what is common in all of this is that the gonads lack the ability to inhibit the Mullerian duct growth. There is no complete differentiation of the Wolffian ducts. There is no proper virilization of the external genitalia. There is no testicular descent, and then there is no spermatogenesis. So another primary differential that we considered before giving this diagnosis was a persistent Mullerian duct syndrome, where you also see a dysgenetic testis. So here the difference is you will always see it in a karyotype of 46XY. And these patients, it occurs due to AMH gene mutation or the anti-Mullerian hormone resistance. So they are all males who will present with inguinal hernia or cryptorchidism, infertility, or some rare tumors are associated. So again, you have three types here. So that can be bilateral abdominal cryptorchidism, unilateral cryptorchidism, or transverse testicular ectopy, where both the testes are present in a hernial sac in the midline. But in all of these cases, the Mullerian structures which you will see characteristically are a fallopian tube as well as a uterus. So they will have a normal external genitalia of a male. Histologically, you will see a decrease in the tubular diameter, no or focal spermatogenesis, like in tubules where you have hyalinized tubules or Sertoli cells only. So this is the short summary. There are many more differentials, but putting together our clinical features and histological features, we gave a diagnosis of mixed gonadal dysgenesis. Our next close DD was persistent Mullerian duct syndrome. The third one was androgen insensitivity, but that comes in where you have a female patient with who has testicular gonads. So that is ruled out. Thank you, ma'am. That's all from me.
Thank you, Dr. Josephine. The case is open for discussion. That was a very nice, beautiful presentation and a nice case, Dr. Josephine. If there are no questions, let's go on to the next presenter, Dr. Lavanya from Madras Medical College.
Yes, ma'am. Good afternoon, ma'am.
Dr. Lavanya, you can start.
Hello, ma'am.
Dr. Lavanya, there's a lot of background noise on your side, please.
Ma'am, am I audible, ma'am?
Yeah, you're audible, but there's a lot of background noise from your side.
I'm 28 years old female, presented with complaints of lower back pain 3 months duration, bilateral breast swelling for 1 month. There was no history of trauma, weight loss or loss of appetite. The patient had no significant past medical, surgical or family history and was not on any medications. The back pain was described as dull, aching, non-radiating, progressively worsening over 3 months. Her menstrual history was regular. Local examination revealed deep-seated, non-mobile, firm mass without overlying.
Dr. Lavanya, you're not audible, ma. Suddenly your volume went down. Hello, Dr. Lavanya?
Ma'am, can you hear me, ma'am?
அதான் ரொம்ப feeble-ஆ இருக்கு உங்க voice.
Now, ma'am, now is it okay?
இல்ல, you started well, but then suddenly the volume goes down.
Okay, ma'am.
Kindly check.
The local examination showed a deep-seated, non-mobile, firm mass without overlying skin changes. Bilateral breast showed diffuse, firm, non-tender swelling without skin changes. No nipple discharge, no palpable axillary lymphadenopathy. MRI was done, which showed MRI pelvis showed a 6 cm lesion of intermediate signal intensity mass involving the right side of the sacrum, showing a destructive bony lesion extending into the spinal canal, infiltrating the right sacral nerve roots and neural foramina also. This is the PET-CT. PET-CT shows a large heterogeneously enhancing mass involving the left breast, and also right breast there is a tiny nodule seen. The right hemipelvis shows a large mass involving the right sacral bone, right side of the sacral bone, iliac bone, and also the upper part of the shaft of the femur involving the right hemipelvis only. And there is also lytic lesion seen in the parietal bone, and also seen are the lung nodules, bilateral lung nodules are seen. This is the PET-CT image. So we received a core needle biopsy of the right soft tissue lesion of the sacroiliac region, which showed a sheets and nest of cells. The higher magnification showing the nested and pseudogranular pattern, an organoid pattern of large polygonal cells with abundant granular eosinophilic cytoplasm and hyperchromatic 2 vesicular nucleus exhibiting atypia and some showing prominent nucleolus, and there is a prominent vascular spaces in between the tumor nest. So with this clinical history, examination, PET-CT and the microscopy, we have the following differentials. Paraganglioma with the same nested pattern, we did immunos. Synaptophysin and chromogranin were negative, so it is ruled out. Alveolar rhabdomyosarcoma, the pattern will be pseudo-alveolar pattern will be there, but sheets of primitive small round blue cells will be there. Also the immunos for myogen and myo-D1 were negative. Granular cell tumor, the pattern is not pseudo-alveolar, but it is positive for S100. So in our case S100 was negative, so granular cell tumor is also ruled out. We considered metastasis from renal cell carcinoma. PAC site was negative, and also the pattern and the endothelial wrapping, the vasculature. So we want to rule out the hepatocellular carcinoma. So EBAR was negative. The another tumor which mimics the same morphology, but so we did immunos for adrenal cortical carcinoma to rule out metastasis. Again, melanine, inhibin, calcitonin negative. No necrosis in our slide, and also the scattered mitosis only seen in our slide. Then coming to PCOMA, HME45 and melanine was again negative. Clear cell sarcoma, again the immunos were negative for the clear cell sarcoma. Melanoma also S1 and HME45 were negative. So the left option is alveolar sarcoma. So we did TFE3, which showed diffuse nuclear positivity in 70 to 80% of the tumor cells, and also we did PASD. PAS positive, diastase resistant, intracytoplasmic granular needle shaped positivity seen in the tumor cells. So with this we came to the conclusion that alveolar sarcoma. We signed out the report. 1.5 months later, we received the core needle biopsy of the left breast lesion of the same patient. We did the H&E showed the same nested organoid pattern of the tumor cells, pseudogranular pattern of tumor cells with the large polygonal cells with the abundant eosinophilic granular cytoplasm and the vesicular hyperchromatic nuclei. We did TFE3 for the case. TFE3 showed diffuse strong nuclear positivity in 70 to 80% of the tumor cells. So alveolar sarcoma. This case is presented is notable for the breast metastasis from a primary gluteal alveolar sarcoma, a metastatic pattern rarely reported in the literature. Bilateral breast metastasis has not been described in any of the tabulated cases. The occurrence of breast metastasis in conjunction with the multiple systemic metastasis underscores the aggressive metastatic behavior of this case, otherwise slow growing tumor. This case therefore contributes to the limited literature describing the unusual metastatic patterns of alveolar sarcoma and highlights the importance of integrating clinical, radiological, histopathological and immunohistochemical findings for accurate diagnosis and management. So why it is called alveolar? Because of the loss of cohesion in the center of the tumor nest creates the pseudo-alveolar spaces. According to WHO 5th edition 2020, this is a soft tissue tumor of uncertain differentiation, accounts for less than 1% of all soft tissue sarcomas. It is a slow growing tumor. Age incidence 15 to 35 years with slight female predominance. It is a high grade tumor, highly vascular. The diffuse nuclear expression of TFE3, the most reliable diagnostic marker, and reflects the underlying ASPSCR1 TFE3 gene fusion. The molecular hallmark of the fusion gene results from the translocation between the X chromosome and the 17th chromosome between the short arm and the long arm regions correspondingly. This fusion leads to the aberrant transcriptional activity, which shows the activation of the downstream oncogenic pathways, including the MET and VEGF pathways signals, contributing to angiogenesis, making this tumor highly vascular, cell proliferation also increased, and also metastasis. So this tumor is more prone for metastasis. So the gene fusion is detected by FISH, RT-PCR, RNA sequencing, and NGS. So this is the summary of the literature review, summary of the reported cases of alveolar sarcoma, including the present case. So most of the cases, the age showed correlated with our case, and also female predominance correlated with our case. Site test, most of the cases in adults were deep-seated regions like deep soft tissue like thighs and gluteal region, and in children it is tongue and the orbit. In our case, it is a deep-seated tumor in the right pelvic region, involving the right gluteal region, but in none of the reported cases breast metastasis was given. So ours is the notable case with right pelvic region involving the gluteal region, alveolar sarcoma with breast metastasis, histopathologically proven. The right breast is not biopsied, and also lung nodules it is not biopsied. So this case is it's a notable case with the presentation of metastasis. So the prognostic factors are, poor prognostic factors are tumor more than 5 cm, older age group, metastasis, bone involvement, brain metastasis, incomplete excision are the factors contributing to poor prognosis. Better prognosis are the age group in children, small localized tumors. So the management is surgical resection with the negative margins remains the primary treatment. Conventional chemotherapy has shown limited efficacy in alveolar sarcoma. For metastatic disease, targeted anti-angiogenic therapies showed some outcomes. Tyrosine kinase inhibitors such as sunitinib, pesopenib, axitinib are used. In addition, immune checkpoint inhibitors such as the atezolizumab can also tried in effective chemotherapy options. Long-term follow-up is essential due to the tumor's propensity for late recurrence and delayed metastasis, and structured imaging surveillance, including the PET-CT, plays a key role in monitoring the disease progression and detecting metastasis early. So these are my references. Thank you, ma'am. I thank my director, Professor Swaminathan sir, Komadi ma'am, Jailakshmi ma'am, Premlata ma'am, Malarmati ma'am for the opportunity.
Thank you, Dr. Lavanya. That was a very nice presentation. So yours is the first case of its kind.
Yes, ma'am.
From
the breast biopsy of the breast is not done, Valar.
Ma'am, biopsy of the breast done, ma'am. This is the core-needle biopsy of the left breast, which we received 1.5 months after the first biopsy.
First biopsy was a gluteal region.
Yes, ma'am. December we received gluteal region. February we received breast lesion.
Left, right also you received, huh?
Right, no, ma'am, no, we didn't receive
not
right.
Not done because it is very small.
Yes, ma'am, small. PET-CT showed a lesion in the large heterogeneously enhancing lesion in the left breast. Almost replacing the entire breast parenchyma. Right breast there was a tiny nodule, and lung nodules were there. Right hemipelvis totally involved. Right parietal lytic lesions also seen, ma'am, in brain.
So it's a multiple metastatic.
Yes,
it's a case of multiple metastasis.
But is there any chance of a coincidence of two types, oncocytoma in the breast and then I was thinking.
Ma'am, we did all the immunos, ma'am.
Yeah. No.
TFE3 was positive.
Madam, good evening, madam. I think I saw the breast, Lavanya, and madam, that case was rather different. It was definitely a malignant tumor, but I didn't think of this alveolar soft part sarcoma, though it had large cells with abundant eosinophilic granular cytoplasm. I also thought like oncocytic ஏதாவது different இருக்குமா இல்லனா secretory அந்த மாதிரி I was thinking like that, and suddenly the group told yes madam, So they gave me the input telling that this case was reported long back with the alveolar sarcoma in the pelvis.
Oh,
So we went back and then did all that, madam, because it was a tough case in the breast rather.
yeah.
The எடுத்தோட நம்மளால சொல்ல முடியல
சொல்ல
alveolar
முடியாது.
sarcoma, it is very difficult only. So that was the
Mm.
show. Thank you.
Oh, yeah. Thank you. Thank you. Thank you. Yeah.
Okay.
Thank you, madam.
Thank you, Dr. Lavanya, and
Thank you,
thank
ma'am.
you, Dr. Jaya, for all the inputs. Thank you, ma'am. Thank you.
Thank you, ma'am.
So we go on to the next presenter, Dr. Bharathi from Stanley.
Good afternoon. Good afternoon, ma'am. Yeah. Good afternoon, ma'am, sir, and everyone.
ஃபோன் பண்ணியிருந்தீங்கம்மா, என்னன்னு நினைச்சோம். என்ன பண்ணோம் அதுக்கு?
The others, please kindly mute your mic.
கால் பண்றீங்க, அங்கிருந்து யாரும் கால் பண்ணுறீங்க? ஒரு வாரம் நீங்க தான் கால் பண்றீங்க, அங்க யாரும் வரமாட்டேங்க. நீங்க வரேன்னு சொன்னாங்க, ஆனா வரல. நீங்க திங்கக்கிழமை வர சொல்லுங்க, திங்கக்கிழமை வர சொல்லுங்க. நான் இதை லீவ் போட்டுருந்தேன், வரவே இல்லை.
Good afternoon, ma'am, sir, and everyone. This is Dr. Bharathi from Assistant Professor from Stanley Medical College. First, I would like to thank a professor and HOD Dr. Selvambikai ma'am, Professor Dr. Valarmati ma'am.
போன வாரமே சொல்லியிருந்தாரு, நம்ம வீக் டேஸ்ல மட்டும் தான் எடுக்க முடியும்னு. அதுவும் சொல்லல அவர்கிட்ட. இந்த வீக் டேஸ் வர சொல்லுமா, 2 நாள், 3 நாள் எடுக்கல, 3 வாரம் எடுக்கல.
The others, please kindly mute yourself.
ப்ரொஃபஸர்லாம் பிரசன்ட் பண்ணிட்டு இருக்கா? ப்ரொஃபஸர் பிரசன்ட் பண்றாங்க.
With this, I would like to go into my presentation. The patient was a 60 years female. She presented with She was a 60 years old female. She presented with an ulceroproliferative mass growth measuring 4 into 3.5 centimeters in the right thigh. CT revealed an ill-defined ulceroproliferative soft tissue lesion measuring 5.3 into 3.9 into 2.9 centimeters in the subcutaneous plane of antero-inferior aspect of right thigh with infiltration into the fascia lata and superior fibers of rectus femoris muscle. There was no deep invasion or bony invasion. So this is how it looked like in the clinical presentation. And the preoperative diagnosis was squamous cell carcinoma. Initially, we received an HMH biopsy where we received 4 fragments, the microscopy of which revealed a small blue nodule in the dermis showing a hyperkeratotic stratified squamous epithelium with focal ulceration with underlying dermis showing a neoplasm arranged in sheets, clusters, singly scattered round to oval cells with moderate eosinophilic cytoplasm with hyperchromatic and vesicular nucleus. Lymphatic invasion was absent. So with this, we gave it as a poorly differentiated malignant neoplasm and we requested for IHC panel. Following which we received a frozen section biopsy where we received a single fibrofatty tissue with 3 nodes. One of the nodes revealed effacement of the lymph node architecture with lymphocytes admixed with neoplastic cells arranged in nests, cards, and as singly scattered cells with scanty cytoplasm and pleomorphic nucleus, and mitotic figures were noted. So considering the previous biopsy, we gave it as positive for malignancy, probably metastatic carcinomatous deposits. So following which we received an excision biopsy specimen with lymph node dissection, inguinal lymph node dissection measuring 6.5 into 5 into 3.5. The external surface and cut surface revealed a circumscribed ulceroproliferative nodular gray-white firm tumor measuring 5.5 into 5 into 3.5 with focal gray-brown hemorrhagic areas. So this is how it looked like. Along with this, the fibrofatty tissue revealed 5 lymph nodes. So the microscopy revealed a skin lined by hyperkeratotic, parakeratotic, and orthokeratotic stratified squamous epithelium with underlying dermis and subcutis showing and malignant neoplasm, arranged in nest, cards, nodules, and a singly scattered round to oval cells with scant cytoplasm and round nucleus with increased nuclear cytoplasmic ratio, fine chromatin, and indistinct nucleoli. Focal area showed salt and pepper chromatin. The intervening stroma showed dense hyalinization with congested blood vessels, hemorrhage, and tumor infiltrating lymphocytes. So with this, we went for the IHC panel. It was diffuse cytoplasmic positivity for synaptophysin, diffuse nuclear positivity for insulinoma-like protein, diffuse cytoplasmic positivity for pancytokeratin, cytokeratin 20, as well as chromogranule. So our diagnosis was Merkel cell carcinoma. Okay, this I have said. Synaptophysin, diffuse strong cytoplasmic positivity, insulinoma, diffuse strong nuclear positivity, and diffuse strong cytoplasmic positivity for chromogranule, cytokeratin 20, and pancytokeratin. It was negative for HMB45, CD45, P40, which rules out the melanoma, lymphoma, as well as epithelial malignancies. So our diagnosis was Merkel cell carcinoma. As the size was more than 5 centimeters, it was categorized as T3, and as it was macroscopically viewable and microscopically confirmed, the node was given as N1B and M0. So coming to discussion, Merkel cell carcinoma is a primary cutaneous neuroendocrine tumor. It's a very rare, highly aggressive tumor. Usually affects an elderly male, average age being 75 years. Usually fair skin, affecting the sun-exposed areas, head and neck, followed by the extremities and the trunk. Generally, it presents as a rapidly growing flesh-colored violaceous blue nodule and plate. This is how it looks like in the clinical presentation. Fleshy to tan brown lesion with nodular ill-defined silhouette with variable ulceration. So coming to the microscopy, it is composed of neoplastic cells, which covers a spectrum of small to intermediate and large cells with fine granular salt and pepper chromatin with nuclear molding and rosette-like structures. Mitotic apoptotic bodies may be seen and lymphatic invasion usually present. And coming to the IHC panel, this IHC would be positive for both epithelial markers as well as neuroendocrine markers, especially cytokeratin 20 and cytokeratin 7, in which for cytokeratin 20, there will be characteristic perinuclear dot-like positivity. And for neuroendocrines, usually synaptophysin along with insulinoma-like protein. The 80% of the tumor is associated with infection with Merkel cell polyoma virus. So that will be positive. That will be showing a diffuse dot-like positivity for monoclonal antibody for large T-cell antigen. So coming to the differential diagnosis, generally it should be differentiated from the metastatic neoplasms of neuroendocrine neoplasms of extracutaneous origin. And with respect to the gross appearance, it should be differentiated from squamous cell carcinoma, keratoacanthoma, dermatofibroma, and if it is a small biopsy, basal cell carcinoma, lymphomas, and Ewing sarcoma. And if there is epidermotrophism, then it should be differentiated from amelanotic melanoma and sebaceous carcinomas. And the last one is a carcinoid tumor. So in us, we were differentiating it from lymphomas, amelanotic melanoma, and neuroendocrine cell carcinoma. So cell of origin with respect to this, initially it was proposed to be the normal Merkel cell because of the presence of cytoplasmic granules, but now it is proposed that it could be from the dermal and epidermal basal stem cells. So coming to the prognosis, 5-year survival rate, if it is localized, is 51%. If there is a regional metastasis, then it is 35. If there is a distant metastasis, it is 14%. So coming to the this table gives you a gist of what are the immunohistochemical panel that should be done for a small blue round cell tumor in a skin. So for ruling out, okay, I think these two, just for the information sake, I have shared it. These are my references. Thank you. This particular case was presented only because of its rarity. It is only 0.2 to 0.45 per 1 lakh population across the world. And in India, it is less than 1% of the total cutaneous neoplasms. Thank you.
Baler,
சொல்லுங்க மேடம்.
I have seen one case in during my dermatology time or in MD pathology, I don't know, I forgot. It was presenting from the axilla.
Okay,
it was first reported as Merkel cell carcinoma. After that, I too have never seen, but close DD was, as she mentioned, I also thought of a neuroendocrine and lymphoma, since the markers have proved this. And very rare entity skin, when we see the small lymphocyte-like cells with a dark staining nuclei, we have to think of Merkel. This is an eye-opener for us.
Yes, ma'am. And this had a metastasis, madam. This case had a metastasis to the node.
Yeah. Maybe they would have, presentation was little different.
Yes, ma'am. Limbla presentation with nodal metastasis, ma'am. And markers proved with proved markers, ma'am.
Yeah, very nice, very nice, very rare presentation. Very good, very good. Second time I'm just, I remember this case.
Yes, thank you, ma'am. Thank you, ma'am. So thank
Welcome.
you, Dr. Bharathi. And we go on to the next presenter. The next presenter can Dr.Indu from Anderson. Who's presenting from Anderson? Is it Dr. Indu or?
Dr. Manikam will be presenting from Anderson.
Okay, please ask him to share the screen.
Yes, ma'am.
Can he share it or should I share பண்றாங்களா Dr. Indu?
Yes, ma'am.
Yeah. Dr. Manikam,
Yes, ma'am.
You can share your screen and start presenting.
Oh, one second, ma'am. Yes, ma'am. Can you share it, ma'am? Ma'am?
Yeah. Just give me a second. Understand. It's going to. Dr. Manikam?
Yes, ma'am.
Yeah,
Good afternoon.
you can start.
Yes, ma'am. Good afternoon to everyone. I'm Dr. Manikam, a consultant pathologist from Anderson Diagnostic and Lab. I would like to thank to Dr. Ashok Parmeshwaran sir and Dr. Indumati ma'am for giving me the opportunity to present this case. Next slide, ma'am.
Yeah, you can continue.
Yes, ma'am. I am presenting the interesting and rare case. 48 years female. It's a known case of SLE on steroid therapy. This is who presented with swelling over the dorsum of the hand. The clinical diagnosis was tenosynovitis. The patient underwent extensive tenosynoviectomy surgery and specimen sent to our lab for histopathological lab investigation to rule out the malignancy. In gross examination,
slides are not moving.
Yeah, it's gross தெரியுதுல்ல sir. You can see it now, sir.
Yes. We are seeing only
No, the slides are not moving, ma'am. We are seeing only the first page. Kindly put it in the slideshow mode.
Yes, ma'am. We received a single grade soft tissue fragment measuring 3.5 centimeter and external surface unremarkable. Cut surface homogeneously grey tan and no obvious necrosis or hemorrhagic areas are seen. Next. So moving to microscopic examination. Next slide.
Enema, what is it?
It's the next slide, ma'am. I want a microscopic scanner view.
Can you see? I'm moving the slide. நான் மூவ் பண்றேன். We are moving the slide.
But
no, ma'am, it is in the grossing page only, ma'am. The slide's not moving.
There's something.
Yes, it's a low power.
இதுலயே போட்டுடலாமா? நீங்க இப்படி we can do it this way. நீங்க அப்படியே present பண்ணுங்க டாக்டர் மாணிக்கம்.
Okay, ma'am. It's a scanner view. It shows the dense collagenous tissue and both sides shows dense cellular and spindle shaped cells, and it is arranged in fascicles. In low power view, the spindle cells administered with chronic inflammatory cells, the lymphocytes and plasma cells, and go for high power. Next slide, ma'am. It shows spindle cells with administered with foamy histiocytes and multinucleated cells and lymphocytes. So based on the overall morphology, its features they are the next slide, ma'am. So differential diagnosis this should be considered, ma'am. First is the inflammatory myofibroblastic tumor. It's same its morphology, spindle cell proliferation of the myofibroblast with mixed inflammation without overt cytological ATP or varying mitosis. And next one is a benign fibrous histiocytoma. It is a benign dermal based nodular lesions, the same, but it occurs in the immunosuppressed patients, and collagen trapping is present in this, which were not seen in this case, in our case. And tenosynovitis, it is one of the DD. It may occur in the autoimmune disorder patients and shows dense connective tissue with inflammatory cells and histiocytes. And hystoid Hansen disease is one of the DD, but the patient is not known case of the Hansen disease. It is look like the morphologically similar features, but it mostly occur in the relapse with irregular or monotherapy treatment patients. And finally, the mycobacterial spindle cell pseudotumor, it is similar morphological features. It's a spindle cell and occur in the immunocompromised patients. It's a morphologically similar features. So considering the morphology, an infectious spindle cell lesions was strongly suspected. So go for the, we think of the special stains, is Jill Nielsen stains. So surprisingly, numerous intracellular acid phosphobacillus in the spindle cell histiocytes. And the next slide, it is a multiple sections, shows abundant intracellular acid phos bacilli. So the confirming the diagnosis of, it's a final diagnosis of mycobacterial spindle cell pseudotumor. Next slide, ma'am. Next slide, ma'am. So these are the diagnostic clues favoring the mycobacterial spindle cell pseudotumor. So first is an immunocompromised patient. Patient is known case of SLE on steroid therapy. And microscopic examination shows a bland spindle-shaped histiocytes, minimal cytological ATP and low mitotic activity. And the AFB state Jill Nielsen stain shows the numerous intracellular acid phos bacilli. These are the diagnostic for favoring the mycobacterial spindle cell pseudotumor. Next slide. So go for the discussions. So mycobacterial spindle cell pseudotumor is a benign inflammatory. It's a tumor-like lesions. It occurs almost in the immunocompromised patients. It includes HIV and some on therapy of the immunosuppressive treatment. And most common site is lymph node, and other site is also occur. It's skin, soft tissue, liver, spleen, bone marrow, brain, and peritoneum. It's very rare in tenosynovium. Tenosynovium is an unusual site. This slide, ma'am. So most caused by, it is a non-tuberculous mycobacteria. It's especially some Mycobacterium avium complex. It's a pathogenesis. It's a normal individual immunity patients. When it is mycobacterial infections, it causes by the mycobacterial infections. It's activate the type 4 hypersensitivity and to form the well-formed granuloma. But in immunocompromised patients, impair the cell-mediated immunity and granuloma, absence of the granuloma formations. The spindle cells, these bacteria bacilli proliferate into the histiocytes to form the proliferation in infected histiocytes and to form the transformation into the spindle cells. So this form the mycobacterial spindle cell pseudotumor. These are my reference articles from the PGH Chandigarh. This is the take-home messages. Yes, ma'am. Think of mycobacterial spindle cell pseudotumor whenever spindle cell lesions occur in an immunocompromised patient. Always perform the Jill Nielsen strain before labeling the lesions of the tumor. It's an abundant intracellular AFP with the bland CD68. It's a positive histiocytes is diagnostic, and correct diagnosis prevents the unnecessary surgery and enables appropriate antimicrobial treatment. This is my reference. Thank you, ma'am.
Hello, did you disprove the gene expert done to say it is a...
Ma'am, advice to the patient and talk to the doctors also, ma'am.
Yeah, because common in our country, this avium complex is rare, and then the presentation is because of the combination of spindle cell with ill-defined granulomas are there without an epithelioid one. More of histiocytes and multinuclear giant cells were there.
But here case, no caseous necrosis and no granuloma, well-formed granulomas are the same.
That's what I said, ill-defined
yes,
only there.
Yes, ma'am.
I thought of first granulomatous as general, then the spindle cell pseudotumor. This name is not very familiar. Maybe we have to, as a DD, we have to see if you see the spindle cell proliferation in a lesion like this. This is the moral of the take-home message you want to give.
Yes.
Good, good.
Thank you.
Okay.
Thank you, Dr. Manikam, and thank you, Dr. Indu. That was a real eye-opener. Can we go on to the next presenter, Dr. Partheeban? Sims.
Yes, ma'am. I'm Dr. Gokul, ma'am. I'll be presenting on behalf of sir, ma'am. Hello.
Yeah, Dr. Gokul, please go on.
Yeah, I'll share the screen, ma'am.
Please share.
What is seen?
Dr. Gokul, yes?
Yeah. Yes, I'm sharing, ma'am. 1 minute.
அவங்க
I hope you're able to
பண்ணும்போது
hear me.
நம்மளால ஷேர் பண்ண பட் அவங்க என்ன ஆக்கி வச்சிருக்காங்க தெரியல அப்பதான் சொல்றேன் நீங்க பேசுன்னு சொல்றீங்க நான் நேற்று சொல்லியிருந்தேன் அவங்க தான் பண்ணுவாங்க அவங்க
Can I start now?
Yeah, please start.
Yeah, yeah. So, good afternoon. I am Dr. Gokul Kripesh, junior consultant from SIMS Hospital, and I'll be presenting a case. This was a case of a 40-year-old female. She was planned to donate a kidney to her husband, and during the workup, it was found that she had an incidental upper pole lesion, which was abutting the renal sinus. The clinical team made a decision that they will go ahead with the transplant by doing a limited resection, and based on the frozen, whether to proceed with the transplantation or not. So unfortunately, I did not have the gross image, but gross, we had received that partial nephrectomy specimen with a solitary 2.7 centimeters size tumor, and with a gross margin clearance of 0.2 centimeter. The tumor was a bit brownish and congested in appearance, and it looks circumscribed. Now, this is a frozen image. Pre-operatively, the diagnosis was actually an oncocytoma. That was the radiological diagnosis. But if you see the frozen, definitely doesn't look like an oncocytoma. It was just definitely a cellular tumor arranged in sheets. If you see closely, there is also a lot of ATP over there, with thick wall blood vessels over here. So we kind of deferred the opinion. We just spoke with them saying that, see, it is not an oncocytoma, but it is definitely a tumor. We cannot tell you whether the tumor is benign or malignant. So we signed out the frozen report as a cellular neoplasm with epithelioid and clear cell features, because some of the cells showed a little bit of clear cytoplasm. And we told them to wait for the permanent sections. However, the clinicians, they decided to go with the procedure because of the clear margin clearance was adequate for them. Now, this is a permanent section. As you can see here, there's a tumor here, kind of has a kind of a mild infiltrating pattern, but there's a nice demarcation with the adjacent normal kidney over here. The tumor appears to be very cellular. There's also a lot of blood vessels over there. Vasculature is increased in the tumor. Again, if you see, the cells are predominantly arranged in sheets. There is some sort of atypia. Some of them shows a kind of inconspicuous nucleoli. But again, you can see well-defined cell borders. Some are showing clear cytoplasm, some little bit of eosinophilic cytoplasm. And here, if you see, you can see some of them are showing this kind of vacuolated appearance. Here you can see this better large cell with a vacuolated appearance, and interspersed between them, a lot of capillary meshwork, a lot of thin capillaries are there. So we were like, what type of tumor is it? Is it a renal tumor or is it something else? So again, higher power, you see a very rich vascular tumor admixed with these polygonal cells with clear to vacuolated cytoplasm. So based on this, we had a few DDs. The common being, is it a clear cell renal cell carcinoma or a chromophobe RCC because of the DTPA and because of the clear cytoplasm? Very rare, but is it a hemangioblastoma? Because those could be those vacuolated stromal cells with a lot of vasculature, but again, very, very rare. So we had to give, and because of the close proximity of the tumor with the sinus, a lot of vasculature and kind of these polygonal cells, maybe is it an angiomyolipoma? So these were the 3 DDs, and we went ahead with IHC. First thing first, what were the negative markers? CK was negative, so kind of ruled out an epithelial tumor. CD10 for clear cell RCC, it's negative, so the clear cell RCC ruled out. CK7, CD117 Amakar, that was a chromophobe. HMB45 was negative, so that rules out angiomyolipoma. So the only DD which we have to now prove was whether it's hemangioblastoma. And before that, PAC was patchy positive, which kind of established that this is from a renal origin tumor. So this is Vimentin kind of positive. This is a kind of denotes that it's a kind of a stromal tumor. The CD31 stain nicely highlights the what I told in the HNE, the vascular meshwork, whereas the tumor cells are negative. And this is alpha inhibin, positive in those kind of stromal cells. No? That was positive for alpha inhibin, and also it was positive for S100. So this IHC staining pattern kind of confirmed our DD of a hemangioblastoma. And hemangioblastomas in the kidney rare. extra neuraxial hemangioblastomas. Around 250 case reports are there. In that, in the kidney, fewer than 20 have been reported. So the classic picture is the lipoblast like epithelioid cells, the cells which I showed you, which has this vacuolated cytoplasm with microvacuoles and a complex network of capillaries. Sometimes the capillary meshwork will be more, giving a kind of a pericytomatous pattern. And these cells are going to be positive for your alpha-inhibin, S100, and NSCN by Menton. Now, these tumors, unlike the ones that you see in your CNS tumors, are sporadic and usually not associated with your VHL disease or syndrome. They will not, most of them do not show the mutation. And the why we are presenting this case is basically it's a diagnostic dilemma. We should realize that all that is clear in the kidney will not be renal cell carcinomas. And proper wording of the report when you're giving a frozen so that you don't alarm the clinician and help them make a decision has been presented. And at the bottom is the article which has kind of done a study on how many of these extra renal or extra neuraxial hemangioblastomas harbor the VHL disease, and they have proved that out of the 17 which they have done molecular analysis, only 3 of them harbored the mutation. And even though they harbored the mutation, they did not present with any symptoms. So, thank you. Very short case. I thank you for this opportunity.
So, hemangioblastoma of the kidney. That's
yes, hemangioblastoma of the kidney.
What is the incidence, Dr. Gokul?
Very rare, ma'am. Case report wise, hemangioblastoma only 20 cases till now, ma'am.
Oh, hemangioblastoma of the kidney.
Kidney,
right.
only kidney, ma'am. The patient does not have any lesion anywhere else.
Okay,
So,
what happened regarding her donating kidney to the her
so
husband?
the patient, she is doing well, ma'am, and she has actually donated her kidney to her husband. Her husband is also doing well. It has now been 2 months since this has happened.
Oh, she has gone ahead with donating that.
Yes, gone ahead, ma'am.
Right. Thank you.
But under low power, it was more like an insular pattern. And then the clear, like a lipoblast cells, what your Manikam is saying, Gokul is saying, it looks like a paraganglioma cells, no?
Yes,
Was it not? Since it's a
no,
kidney, we have to think in the line of thing.
Correct, madam. But we had done synaptochroma also. It was negative. I have not put it away, but synaptochroma also.
Yeah, we have to go by.
Yes, ma'am.
But when on histopathology description, your coming conclusion will be shifted to the small round cells, and then the pattern. The pattern is more important.
Yes.
Then the vascularity was not very clean in the. And the slide which you have focused for the discussion was very well seen. What you have sent for the. What you showed us in the previous thing,
yes, ma'am.
We never make to think of that. Anyway, you keeping the trump card with you. That's good.
It was actually a very difficult case, ma'am. We were breaking our heads. Then only something hit my mind that why can't it be hemangioblastoma, which is sitting in the brain, similar to that? And then we went ahead with the markers and came with this diagnosis.
Cerebellar hemangioblastoma generally used to get.
Yes, ma'am.
Common exam slide for us those days.
Yes, ma'am.
Okay. Yeah.
Thank you,
so
ma'am.
much.
Thank you, ma'am. Thank you, Dr. Gokul, and thank you, Dr. Partheeban. That was a nice case. Can we go ahead with the next presentation, Dr. Sukanya from Railways?
In case
Hello, ma'am. Is my slide visible?
Yeah, your slide is visible.
Okay. I'm Dr. Johanna. I'm a DNB pathology resident from Southern Railway Headquarters Hospital. I'll start with my case presentation. A 75-year-old male, known case of thymoma, post-thymectomy done in 2025, had presented with complaints of dyspnea on exertion, generalized fatigue and tiredness, on and off giddiness for 5 days. He had received 10 units of transfusions in the last 10 months. On initial assessment, he had pallor and clubbing with normal pulse rate and blood pressure. Systemic examination was otherwise unremarkable. His laboratory findings showed severe anemia with a hemoglobin of 4.3 grams, RBC count of 1.68 million, MCV, MCH were normal, WBC and platelets were normal. Reticulocyte count was 0.2% and reticulocyte index was 0.08. His ferritin and vitamin B12 levels were also normal. So overall, he showed a picture of severe anemia without hemodynamic compromise. Peripheral smear showed normocytic normochromic RBCs, WBC platelets normal, no hemoparasites, no dysplasia, and no evidence of hemolysis. Impression was severe normocytic normochromic anemia. His reticulocyte count was very low, 0.2%. And PET-CT findings at the time showed inflammatory etiology in the sternotomy site with no evidence of lymph node or distant metastasis, and no other significant findings were seen. So bone marrow aspiration was done. It was particulate and hypercellular for age. So overall cellularity is preserved, arguing against aplastic anemia or other bone marrow failure syndromes. In high power, we confirmed the near absence of erythroid precursors with preserved myeloid and megakaryocyte lineages. There were increase in mast cells, plasma cells, lymphocytes, and mild eosinophilia. His differential count showed erythroid of only 0.6% with few scattered erythroblast. So ME ratio 97:1, which is profoundly elevated. Bone marrow biopsy was also showing normal to mildly hypercellular marrow spaces for age, with similar findings of increased plasma cells, increased lymphocytes, eosinophils, and a lymphoid cell collection. So final impression was hypercellular marrow with severe erythroid hypoplasia consistent with pure red cell aplasia.
Yes, yeah.
His past history, he was diagnosed with thymoma in 2025 with a large anterior mediastinal mass, and he underwent thymectomy in June 2025. So grossly, it was a capsulated brown nodular mass, 12x10x7 cm with a well-circumscribed, vasellated, congested outer surface and a lobulated and gray-white cut surface. So on microscopy, it showed a circumscribed mass with multinodular appearance separated by fibrous septa into nodules of varying sizes. There was also a foci showing infiltration into the capsule but limited by a thin fibrous membrane. The tumor showed type A areas with spindle cells, type B1 areas with abundant lymphocytes, and type B2 areas with mixed population of epithelial cells and lymphocytes. So impression was type AB thymoma. So I'll discuss about pure red cell aplasia after thymectomy. So PRCA is a rare bone marrow failure condition characterized by isolated normocytic normochromic anemia with a low reticulocyte count. It is defined as profound reduction of erythroblast precursors less than 1%. And PRCA is the second most frequent paraneoplastic syndrome associated with thymic tumors, the first being myasthenia gravis. So PRCA may be found at the time of diagnosis of thymoma or even several years later. So studies have shown, one of the study had shown a median 56 months after which PRCA was discovered, and another study showed 80 months after which PRCA was discovered. So etiology of PRCA is thought to be an autoimmune response with consisting of role of self-reactive T cells, clonal erythroblast disorder, and anti-erythropoietin antibodies. So pathophysiology in the setting of thymoma, there is immune dysregulation, and there are three mechanisms involved. Firstly, anti-erythroblast antibodies, which block the differentiation of erythroblast, leading to decreased erythroid progenitors, and anti-erythropoietin antibodies, which inhibit the signaling of erythropoietin, leading to decreased erythropoiesis, and cell-mediated suppression involving autoreactive T cells, natural killer cells, and large granular lymphocytes, all of which lead to decreased erythropoiesis. So recently, PRCA is increasingly recognized as a T cell driven disease and not just antibody mediated. And clonal T cell populations are found in multiple subtypes of PRCA, such as primary PRCA, thymoma associated PRCA, autoimmune, and LJ leukemia associated PRCA. This supports the idea that immune dysregulation, especially T cell activity, is central to disease pathogenesis. STAT3 is a key transcription factor which regulates inflammation and autoimmunity, and STAT3 mutations are found in CD8 plus T cells in PRCA, which is not typically seen in aplastic anemia. and which also explains why PRCA selectively affects the erythroid lineage, unlike aplastic anemia, which causes pancytopenia. So this slide shows the relationship between thymoma histological subtypes and pure distal aplasia. So studies have been done over several countries, and studies in Asia showed predominantly AB subtype, and European countries showed predominantly lymphocyte-rich B subtype. So no single histological subtype is exclusively linked to PRCA. So to conclude, the latency between thymectomy and onset of PRCA is variable and unpredictable, thereby necessitating prolonged follow-up in thymoma patients. And individuals with thymoma should be evaluated for PRCA with a thorough hematological examination at each follow-up. These are my references. Thank you.
What is the age of the patient, ma?
75.
Oh, 75. Okay.
That was a nice correlation. That is a PRCA occurring after a thymoma.
Typical history is very helpful.
Yeah,
but there is no history of drug or parvovirus.
Yeah,
no, ma'am.
Not.
Infection was ruled out, ma'am. It was tested and negative.
And there was
he has to
other
go down.
Bone marrow was the plasma cells was little increased. How to contribute that?
So reactive.
Reactive. Okay. Very nice presentation was very. But
Thank
age.
you.
Thank you, ma'am.
Madam, can we go on to the next case, ma'am? Thank you, Dr. Jonah. That was a nice presentation.
Very rare cases today
rare
also,
case. Yes, ma'am. Yes, ma'am. Usually we read
adding,
up thymoma association with PRCA. Just now we have seen a case.
We have read in the book only.
Books, it just comes. So it's so nice to see the case.
Bring out.
So thank you, Dr. Jonah, and thank you, Eril ma'am. And let's go on to the next presenter. Sir Krishna Kumar, sir. Can you share your... Sir, good afternoon, sir. Welcome, sir.
Once again, we'll congratulate him on the presence of all the city pathology group.
Yeah, congratulations, sir. Congratulations.
Thank you, madam. Thank you.
Send a message, but since we are able to talk to you, you're adding one more feather on your cap.
Cap. Already there are too many feathers on his cap.
Too many feathers.
Are we able to see, madam?
Yes.
Yes, sir.
Madam, this is first patient from referral from Hyderabad with a cystic. Are you able to see the slide, madam?
Yes, sir. Yes, sir. Please.
It's a cystic lesion in the lid margin and which recurred after the laser burn. And histopathology shows epidermis and multiple cystic component. Higher magnification shows the cystic component having this papillary-like structures, and you find these papillary-like structures and plasma cells. So
study, more
papilliferum. So we diagnosed papilliferum with other cystic apocrine and eccrine adnexal proliferation, madam.
Yeah, vulva also we can get usually.
Yes. This case is from Bangalore. A 2-year-old child having a clinical diagnosis of hemangioma of the lid. The pathologist from Sankara Hospital sent the slide to us. Looking at it, it looked like a neovoid condition with epidermis and dermis showing epithelioid cells with melanophages. I have even marked the caminobodies. So I know we are looking at a spitzoid nevus, but since the child was less than 10 years, so I sent the images to, because this is the third case of spitzoid nevus which I am seeing. I had a dilemma whether to call it as a spitzoid nevus or atypical. Definitely cannot be a melanoma. But looking at the prominent nucleoli, I was a bit concerned. Shared the images with Dr. Priyadashni Nagarajan of MD Anderson. She told KK, usually we do full workup after the age of 10 for spitzoid neoplasm. but you cannot call it as a nevus because of the prominent nucleoli. And so we, in concurrence with that, I gave a diagnosis of atypical schizoid melanocytic nevus, and we asked for a K67, HMB45, PRAME, and P16, because if P16 is lost or PRAME is positive, at least I can tell whether the prognosis is good or bad. But I understand the patients were not willing for immunohistochemical markers, and so at this stage we don't have further follow-up. So at this stage the diagnosis remains as atypical schizoid melanocytic nevus, and we wanted this immunohistochemical markers. This is rare. This is my third case of schizoid lesion. Next is from Ainu Hospital. A boy, sudden onset ulceration of penis, and the slide had come, and he was tested for HIV, was negative, syphilis negative, no other comorbidities. He does not have any inflammatory bowel disease. Biopsy showed in the dermis a lot of neutrophils with some vascular damage. I was contemplating whether it's a primary vascular damage or secondary vascular damage because of neutrophils. Higher magnification, you can see the vasculitis, and gram stain fungus negative. And so we made a diagnosis of pyedoma gangrenosum. Patient was put on cyclosporin and steroids. After 1 month, the lesion had completely healed. And the other diagnosis suggested by one Dr. Professor Patrick Cosidian was, could it be Behçet syndrome? However, the X-ray studies for Behçet were negative, and the boy did not have any oral lesions.
Oral lesions should be there.
And so this is the histopathology where all the stains for bugs were negative, X-ray studies for Behçet were negative. So this was a pyedoma gangrenosum, so presenting as a solitary ulcer in a young boy. This is very, very rare, and Dr. Venugopal Reddy, who had managed the case, said patient is doing well. So this is the first time I am seeing a pyedoma gangrenosum, the penis. That was the thing.
Yeah, sight is very uncommon.
Yes, madam.
We have seen at the back and other lesions.
Yes, these are the cases, madam.
Oh.
Thank you, KK sir, for those three nice cases of
Potters.
Yeah, yes, ma'am. Thank you. Thank you so much for sharing those cases, sir. And can we go on to the next presenter, the final presenter of the day?
Oh, one more.
Dr. Ramya. Dr. Ramya from Newburgh.
Oh, the case was not shared, illa?
Share panlan, yeah. Dr. Ramya, please share your screen.
Okay.
Dr. Ramya, are you there? I think Dr. Ramya, if you're not there, we can
wind up
for the day, and we can have your presentation maybe in the next city pathology meet. This one is a
343.
Yes, ma'am. This one is a 49th city pathology meet, and so next month will be the TAPCon, and then we were all contemplating about meeting in person for the 50th city pathology meet.
Sure.
We'll discuss and we'll decide, ma'am.
Yeah, I will join definitely, and we'll present a case from Bharathi.
Yes, ma'am. In person vechikalam mari sonnanga.
Pannalam.
For the 50th meeting in person, we'll discuss and come to a consensus, ma'am.
Okay.
So thank you.
TAPCon
TAPCon அடுத்த மாசம் மேம், அதுக்கு அப்புறம் தான் ஆகஸ்ட்ல. July. So thank you all the presenters, and thank you all those who are here, and for the wonderful presentation. Thank you, ma'am. Thank you, Edil ma'am, for all your inputs. You're all the backbone.
I'm in Bangalore.
Ma'am, நீங்க பார்சிலோனால இருந்தாலும் நீங்க பார்ட்டிசிபேட் பண்ணுங்க.
அப்படி இல்லப்பா, சும்மா எவ்வளவு நாளானாலும் கேட்டுக்கிட்டா நல்லதுதான். தெரியுமான்னு இதெல்லாம்.
Yes, ma'am. Definitely. It comes to your table.
கற்றது கைமண் அளவுப்பா, கல்லாதது உலக அளவிற்கு.
Thank you, ma'am. With that nice line, we close city pathology for the 49th city pathology meet.
Thank you, Valar.
Thank you, ma'am. Thank you.
And for cardiac myopathy, heart is waiting for you in Bharathi.
Yes, ma'am. Thank you. Yes, ma'am.
Bye.
Thank you, Sita Lakshmi, ma'am. Thank you, all the
Bye.
presenters. Thank you, ma'am. Thank you.
Thank you. Thank you.
Keep your dress.